and share my screen. All right, so we kind of watched little video clips on blood clotting and on TPA last time, kind of things related to clotting disorders. And then we've got some other things that you'll just kind of want to be aware of that can cause problems with either too much clotting or too little clotting. Pretty much every orthopedic surgery patient, at least lower extremity wise, that stays overnight in the hospital is going to have TED hose on, which are thromboembolic devices. That's what TED stands for. It's different than like TED Talks, different than like Ted the creepy teddy bear either, whatever movies those are. I didn't watch those, but they're basically just usually they're white, and they usually have a hole at the toe purposefully so that you can peel it back a little bit and pinch the person's toenails to kind of check how their peripheral circulation is in their foot. So that's why there is a hole in the toe always on those things. Your knee replacement patients, hip replacement patients, hip fracture patients, almost all those are going to have the TED hose in place. With the knee replacement patient, they'll usually just have it on the non-operative leg because you've got too much of a bulky dressing on the surgical side to really put that on there. But they often come out with like a, usually first day they'll have like from toes to mid-thigh ACE wraps over the top of their bulky dressing that's going to catch any kind of bleeding from the surgical site. And then they'll usually kind of shrink that down over time. And then once they get discharged, then they'll usually take that extra stocking home. As long as they have their staples in, they can't really put that on because the staples would dig into that, the hose. They'll use them for other type of patients too. The other things that they'll do in addition to the TED hose are very commonly patients will get what's called Lovenox injection. Those are usually given in their belly. My dad had pneumonia really bad at the start of the year, and they were giving him Lovenox injections. And it's really just anytime you're much less active than you previously were, you're going to have risk of blood clots, especially in the lower legs. We rely on that muscle pump action of the calf muscles contracting to kind of help promote return of blood flow on the venous side of things. And when we're not moving around, not getting up much, then that blood tends to kind of stagnate in our lower legs and increases the risk that the red blood cells in particular will start kind of clumping together and developing into some clots. A lot of times patients will also be given heparin through their IV, and that's another anticoagulant medication. That's kind of a short acting one, but it is pretty common. Those many times when you have a patient that's in home health, they'll actually continue getting Lovenox injections for a period of time as well after surgery. So blood clots are a very real risk, and it is something that we need to kind of keep an eye out for. And in particular, kind of the signs of DVT would be the main things that we'd watch out for. I think in pathology, we probably talked a little bit about some of the different cardiac disorders, and I think I probably mentioned atrial fibrillation. That's another common cause of blood clots, and that's just that if the atrias are not contracting in a good synchronous fashion, the blood will tend to stay in those upper chambers a little too long. And again, it allows the red blood cells a chance to start forming little clots, and then they get pumped out to the rest of the body and can cause complications. And then kind of on the other end of the spectrum, we've got hemophilia, which is patients that have that, it's a genetic thing, they lack the clotting factors that help stimulate blood clot formation. And there's a couple different types of hemophilia, but it is something that we have to be aware of. And we also have to be aware that when people are taking anticoagulant medications, whether it's something like Coumadin, which is the most common one that you'll see given orally, or any of these IV type ones, those folks, if they fall, have a big time risk of major hematoma formation, excess bruising, because they just can't form that clot to stop that tissue damage at the capillary level. So they'll tend to have a much more exaggerating bleeding response. And so a hemophiliac patient would be the same thing. If we have one of those patients fall, then they can kind of keep bleeding for a long period of time. It's not that they won't ever form a clot, but it just takes a lot longer for that to take place, and a lot more blood loss occurs. Um, Hemophilia was used to be really common in a lot of like royal families that did a lot of inbreeding, basically, to try to not let the gene pool get too far out of their little close-knit royal group, and that was kind of a sign. I think the Russian czars had a big history of family members with hemophilia. Um, so don't marry your cousins. Okay, I'll just put that out there. At least go a couple removed before you think about doing that. All right, I'm going to skip through a lot of the anatomy stuff about the heart so we can get into more of the physiological components. This is all stuff that we've talked about in other classes, so I don't feel a big need to go over it again. All right, so we look at the cardiac cycle, and that's just the term that we give for one complete contraction and relaxation, essentially, is a cardiac cycle. So we have systole and we have diastole, and those are our two numbers in blood pressure. Systole is the bigger number. That's the pressure in the arteries when the heart's actively contracting. Diastole is the pressure in the vessels when the heart is in between active contractions. And when we talk about the contraction phase, it really is just referring to ventricular contraction. The atria component is important, but when the atria contract, the blood still stays in the heart itself. So that term systole and diastole are specific to the ventricular phases of the cardiac cycle. When we look time-wise, when the cardiac muscle is going to follow the kind of action potential all or none principle, and we don't really prolong how long the contraction takes. Once we tell the heart to fire and activate the nervous system kind of inherent within the heart muscle itself, it's going to fire, and it's going to fire pretty quickly. Where we get some variation when we look at slow heart rates versus fast heart rates is going to be more in how long is diastole taking. So when we look at this slide and it talks about 0.3 seconds for systole and 0.5 seconds for diastole, that's assuming kind of a resting heart rate of about 70-ish, which is kind of that average that we see for adults. If we're beating it, 50 beats a minute instead of 70, the systolic phase is probably going to be about the same. It's just that diastole phase would be a little bit longer, maybe like 0.7 seconds. Then that would be like a 60 beat rate. If we're really pumping quickly, like we're exercising and we're pumping at 150 beats a minute, then you probably will see systole shorten just a little bit, because we're going to try to more rapidly activate as much muscle mass as we can in the heart, so we get a really good, strong, forceful contraction that pumps out a lot of blood. But it would probably only go down to like maybe 0.2 seconds. It takes a while for heart muscle to contract relative to skeletal muscle, and we'll look at some of those differences there. So this kind of ratio that we see displayed on here is going to vary depending on how fast or how slow the heart rate is.
So what would happen to the diastolic rate with heart rate up to 150?
It would be a lot shorter for sure. If we're looking at, maybe the systole is 0.2 seconds, then diastole might go down to like 0.3 seconds. And so then if we have half a second, that's basically what we would kind of expect at 120 beats a minute. So if we're looking at, higher heart rates, 180 or something like that during a more vigorous type of activity, then proportionally that's going to shorten that much more. But in general, it is pretty safe to consider that diastole is always going to be longer than systole. That's a general rule of thumb that we'll tend to see. And when we calculate what's called mean arterial pressure, it does take that into account, that the time period when diastole occurs is generally longer than the time period when systole is going to occur. All right, so I think we've talked about these terms in some other classes, whether it was in anatomy or pathology. I can't remember because I just teach too many classes, I think, at this point. But we got end diastolic volume. And again, diastole is that resting phase. So that's when the chambers are the most full, essentially. When we talk about end diastole, that's the end of ventricular relaxation phase. So it's essentially, we would have the atria contract, and then right before the ventricle contracts, that's that period of end diastolic volume. So that's when the ventricles are the most full. And systolic volume is the other end of the equation. As soon as the ventricles finish contracting, have emptied as completely as they can, then that's that end systolic volume. That middle term, stroke volume, is essentially the difference between those two. How much was in the heart chamber when it was full versus how much is in the heart chamber when it was empty. And the difference is, what did the heart pump out? Whether we're talking about the right side of the heart pumping it out to the lungs or the left side of the heart pumping it out to the body. Usually these terms are meant to refer to the left side of the heart because we're talking about what is getting pumped out into the systemic circulation. And so that stroke volume term is really what's leaving the heart, going through the aorta, and then going out all those different branches of the arterial system to deliver blood to the brain, to the arms, to the liver, to the stomach, to the legs, wherever. That last term, the ejection fraction, is basically the ratio between these first two values. Of the total amount of volume that we had in that left ventricle, that end diastolic volume, how much of that percent left when we created the stroke volume and pumped things out. And so normal for a healthy person is roughly about 60%. So we still have about, even after the left ventricle contracts, there's still about 40% of the original blood that was in that chamber before it contracted that remains in that chamber. So it's not a super efficient mechanism. If you're lying down, it's going to be a little bit higher because your heart now doesn't have to pump blood uphill against gravity like we would when we're sitting or standing. The aorta is coming off the top of the heart. So to push that blood out of the ventricles, it has to overcome the effects of gravity to do that. And laying flat is going to make it easier. Standing on your head would make it even easier because then we'd have that downhill gradient where gravity is really helping us a lot. So definitely want to know how to understand those terms. As far as what's happening to help blood move through the different chambers of the heart, it's really all about pressure differences. And just like diffusion, things want to go from high pressure to low pressure areas. They're going to follow those kind of force, I guess I'm trying to think of the term. It is like a force gradient, essentially, instead of like a chemical gradient. But it's just easier to flow where there's less back pressure. And so when there's areas of the body with lower pressure, it's easier for the blood to just move from where it's really compressed at a high pressure to an area that has lower pressure. So if we think about the ventricles, they're going to contract from the bottom up. So we send the electrical signal through the center part of the heart, through the septum. It's going to disperse around the apex of the heart, the very bottom part of the heart. If we look at my little model, so we're talking about this part first. So as the lower parts of the ventricles contract, it's basically just squeezing together, and that's going to start pushing that blood uphill. The atrioventricular valves between the atria and the ventricles are kind of arranged this way so that blood can flow down through them easily from the atria. But when we start pushing blood up from the bottom as the ventricles contract, that's going to close those valves off. And so now that blood is trying to flow up and it hits this blockade where the valves have closed. And that's going to force it to go to the only other place where it can leave that chamber. And so that's going to essentially make it divert either to the pathway to leave the pulmonic valve if it's going to the lungs, or to be forced out through the aorta if we're talking about the left ventricle. So by closing off access to the atria, that's what drives the blood to actually leave the two ventricular chambers of the heart. Once we finish systole, and the ventricles start to relax and open back up, now blood wants to flow back down into the ventricles. And the valves for the pulmonic and the aortic valve are oriented more like my hands are here, so that as gravity pulls that blood back down towards the ventricles, now those valves will shut and it won't be able to re-enter the ventricles. Think about like if you have a really windy day and you like open your door and then kind of let the door go and that wind just slams that door shut. That's kind of what's happening. As the force of that contraction loses momentum, the blood that was pushed up through the aorta now is trying to backflow. And the same thing would happen on the right side of the heart when we look at the pulmonary arteries as well. We're going to have that backflow, and that's going to close the valves off when the valves are all working correctly. So the valve closure that occurs with ventricular contraction and ventricular relaxation is what we listen for when we're listening to somebody's heart to see if it's contracting correctly. And so, our expectation for you guys as PTA students is not necessarily to be expert at diagnosing heart sounds, but you should have a general idea of what normal sounds like, so that if you are listening to a patient's chest, you can kind of recognize that doesn't sound quite normal. And then you would know that we need to probably refer that person back to the physician, to the cardiologist, if they have that consult. It might be something that you see on their chart, that they have a history of a heart murmur. And then when you hear it, you may not necessarily need to make that referral because it's already listed, they're already aware of it. It's probably not different than what the physicians heard. But if it's not documented and we are hearing abnormal sound, then we need to let somebody higher up than us know that. And so for you guys, you can certainly notify the PT that's working with you. Or in some cases, you might be able to just contact the physician directly. It kind of depends on what setting you're in and how that arrangement is kind of working. So we talked about these two distinct sounds of a lub and then a dub. And I'll play this little video clip. Hopefully the sound will work on it so you can kind of hear what normal is and then what a murmur kind of sounds like. And so the lub is actually when the ventricles are contracting and squeezing from the bottom up. It's essentially the sounds of the aortic, the AV valves closing. And then when the ventricles finish contracting and have pushed the blood out of the ventricular chambers into either the aorta or the pulmonary arteries, then the dub sound is essentially those two upper chamber or those two lower chambers valves closing, either the aortic valve or the pulmonic valve. And so it is a pretty distinct sound, and that's kind of what we're looking for a normal heart rhythm. And so we call that the first heart sound is the lub, the second heart sound is the dub. We do have like a S3 sound and an S4 sound. Those are generally abnormal heart sounds. So let's watch our little clip here. Assuming it's going to play for me.
When a healthy heart beats, it makes a lub-dub sound. The first heart sound, lub, also known as S1, is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow as it passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated. Heart murmurs are whooshing sounds produced by turbulent flow of blood. Murmurs are diagnosed based on the time they occur in the cardiac cycle, their changes in intensity over time, and the auscultation site where they are best heard. Examples of conditions associated with common systolic murmurs include mitral valve regurgitation, when the mitral valve does not close properly and blood surges back to the left atrium during systole. The murmur starts at S1 when the AV valves close and maintains the same intensity for the entire duration of systole. This hollow systolic murmur is best heard at the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. when the aortic valve does not open properly and blood is forced through a narrow opening. The blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve.
All right, we're not going to watch the whole thing. I just wanted to let you kind of try and start hearing the difference between that, and hopefully you can kind of, when we have the normal valve closures, we get a very distinct, separate lub-dub sounds, and when we have that murmur, essentially it's the backflow of blood in some direction that is making more turbulence, and so that's what they're hearing. It kind of muffles the sound and kind of prolongs the sound between the S1 and S2, so it's a little bit more continuous. And literally, it is, you're hearing the blood flow in the wrong direction, is essentially what a murmur amounts to. And most of them are going to be due to problems at the valve itself, that the valves are not closing correctly, and some amount of blood is escaping and being misdirected into the wrong chambers, going backwards, essentially backflow blood. All right. So electroactivity, let's kind of talk about this because this is definitely a big physiological thing. We've already talked about the heart as in general, and we've kind of reviewed where these electrical components are in both anatomy and I think probably in pathology. So SA node is where we have our dedicated pacemaker cells. These will spontaneously depolarize. They don't need a signal from the brain. They don't need a signal from the autonomic nervous system. They have a lot of leak channels that allow ions to escape. And so they're not really able to hold a steady resting membrane potential. Pretty much as soon as they fire, they go back to the kind of that baseline, and then they immediately start ramping back up to fire again. The rest of the heart's contraction is going to be dictated by the nervous system wires that are basically within the heart itself. So we go from the SA node. Once that depolarizes, it's going to initially kind of depolarize the right atria, but very quickly it's going to have those dedicated gap junctions that allow for that electrical signal to travel over to the left atria, so that we do end up getting a fairly simultaneous contraction of both the right and the left atria. Once that contracts, we have a slight little delay until the AV node becomes activated. And then once the AV node fires right there at the kind of at the base of that right atria, then it's going to send that message through these nervous system pathways of the bundle of His is kind of this next section. Once it splits, then they become known as the right and left bundle branch. And so each bundle branch is going to go to one ventricle or the other. We're looking at just this cutaway view, but it's important to recognize these nerve branches are going to basically kind of encircle the entire heart as it flows out. And when we get down to the bottom of the heart, the apex, then we're going to have additional branches that split off, and those are the Purkinje fibers that are then going to penetrate into the actual myocardium of the ventricles and cause them to begin their depolarization process. When we talked about nervous system depolarization and skeletal muscle depolarization, we went over the different membrane potentials, and the heart's going to work basically the same way. There are some differences in how quickly we can depolarize the heart muscle, and then there's some differences, especially when we look at the pacemaking cells. So we'll kind of talk about those as we look. All right, so this graph is showing not what happens with the SA node cells, but just the other myocardial cells that are going to be stimulated by the Purkinje fibers and that deliver that electrical signal to the muscle itself. Once those nerves fire, we're going along here at our baseline, and in this picture it's showing at about -85, -90, which is what they think is kind of the normal resting potential for cardiac cells. At roughly -40, that's when we're going to have a massive opening of sodium channels that are going to let that big depolarization take place. So if we've activated the SA node, activated the AV node, bundle of His, bundle branches, Purkinje fibers. Once those Purkinje fibers basically start to stimulate the myocardial cells, they're going to fire quickly and get a really rapid flip of polarity, that depolarization. And then, unlike like when a nerve depolarizes or when skeletal muscle depolarizes, we usually see a pretty rapid downslope with those two types of tissues. With heart muscle, we see a longer kind of plateau period before we get the rapid downslope. And that's believed to kind of help all the different heart muscle finish their contractile property. Again, we're contracting from the bottom up. So we're going to activate the most inferior muscle cells first, and then progressively kind of work our way up through those ventricular chambers. So we want that to be a little bit prolonged so that we get this really effective kind of squeezing, milking, kind of pumping effect. So we do have this little bit of a delay, and it is caused mostly by these calcium channels that are kind of stay open longer and let a more constant flow of calcium coming in that kind of helps offset the amount of potassium that we're losing. When we think about a nerve cell firing, pretty much is we get the big up spike when the sodium channels open, and then we hit that peak, the sodium channels essentially close and the potassium channels open, and we see a really rapid downslope. And so heart muscle is a little different in that we have these additional calcium channels that open. And again, all three of those ions are positive, but the fact that we are having these many calcium channels stay open kind of offsets the amount of positive charges that we're losing. So it takes a little bit longer to kind of reset and be ready to make that tissue fire again, because we've got to get back down below baseline before we can activate those cells to fire once again. So these refractory periods definitely are important. And if you think about the difference between heart muscle and skeletal muscle, heart muscle is going to contract and it has to immediately relax. If we don't let the heart muscle relax and it stays all compressed and tightened, there's no way for more blood to flow back into the heart chambers. There's also no really good way for blood to circulate through the heart muscle itself. As long as the muscle's contracted, it's going to crimp down on all the little capillaries that are trying to deliver blood to the myocardial cells themselves. So it's critical that the heart has a true relaxation phase to allow the chambers to refill with blood, but also to allow the heart muscle itself to get good perfusion so that it can get the oxygen and glucose it needs, so that it has a chance to get rid of the waste products that it's producing as a result of its cellular metabolism. So we really need these distinct refractory periods. It's not like if I'm lifting weights and I pick up a heavy weight and it's taking me like 4 or 5 seconds to complete the motion. You can do that with skeletal muscle because you can kind of shift around which motor units are active. You can substitute in some different muscles that might still help with that action. And you're able to sustain it for a more lengthy period of time. But with the heart, it's got to contract and then it has to relax. Otherwise, it's just not going to be able to stay alive itself, and it's not going to be able to continue to deliver blood flow to the rest of the body. So those refractory periods are definitely important. All right, we talked about those conducting tissues. So I'm going to zip through that a little bit. So if we cut the vagus nerve, which they've done experimentally, probably not in people, but in animals, they may have done some human experiments where they maybe anesthetize it or something so it can't work, but they're not going to typically cut it in a person. But if we eliminate that signal, that influence of the parasympathetic and sympathetic side of the autonomic system, and the heart is just left to do its own thing, the SA node will basically set our heart rate at roughly 100 beats a minute. If we are having a lot of parasympathetic influence, that rest and digest phase, then that will tend to come down even more. And for most of us, if you have that average 70 beats a minute kind of resting heart rate, then you're getting more sympathetic influence, or excuse me, parasympathetic influence at rest, and that's what's making it go from 100 down to 70. When we get that fight or flight phase going on, and we're in that crisis situation, we need that heart to beat faster so it can deliver enough blood to the body so we can respond to that dangerous situation. And that's when the sympathetic side is going to influence the vagus nerve and make the SA node fire a little bit faster. It will help the SA node make more of the heart muscle contract at a given time so we can increase the force of contraction as well as the rate of contraction. Now, you do have people that develop problems in their SA node, and that's the most common reason people get a pacemaker is that something's gone wrong with the cells in the SA node that are supposed to be in charge of setting that heart rate. And so we need to use an artificial electrical stimulation to basically replace the signal that the SA nodes should just be generating on their own. The most common cause, they'll call that sick sinus syndrome, so SSS. And that's where we will typically put in a pacemaker for that person. If they don't get a pacemaker and the SA node is not working, the heart will still contract. The AV node essentially takes over that role, but it's a much lower rate. And average, if the AV node is in charge, then we think the average rate that the heart will contract it is about 40 beats a minute, which if you have a really strong heart, 40 beats a minute is not that big a deal. But for the average person, if they're only pumping 40 beats a minute, that's a big enough rate to kind of supply blood at rest to kind of keep things functioning at the bare minimum. But as soon as that person tried to do any work, they're going to be limited. And if they have an issue with their heart where their heart is not very strong, then that 40 beats a minute might not amount to a big enough stroke volume because the heart can't contract forcefully enough to really deliver enough blood to all the tissue that the body needs. So that can be a very dangerous rate. My resting heart rate is pretty much always in the 40s, but I have a really big stroke volume. But for the average person, and especially when we start getting older and more deconditioned, if you start having a 40 beat a minute rate, that person's going to have a lot of limitations from what they can accomplish. So that pacemaker can be very helpful by allowing the body to get back to a more normal resting heart rate after they put that thing in. So when we look at our EKG, again, I think we talked about this a little bit in pathology. You will want to know kind of what each of these little bumps and squiggles represents. So our P wave is atrial contraction. The QRS complex, these bigger spikes, are the ventricular contraction. And there's a lot more muscle mass to the ventricles than there is to the atria. And so that's why we see a difference in height, that amplitude. That's a reflection of how much electrical activity is occurring. A bigger spike means more muscle mass is contracting and then repolarizing. So that's why the height of that QRS is so much bigger than the P. Now, after the atria contract, they have to repolarize so that they could be activated again the next time the SA node tries to start the heart rate. And atrial repolarization takes place at the same time as ventricular contraction or depolarization is taking place. So we don't really see a distinct amount of electrical activity that represents the atria resetting themselves. The ventricles, on the other hand, after they contract, we have that slight pause, that kind of refractory period, and then they're going to repolarize. And so that T wave, this last little bump, is basically the ventricles resetting themselves so that they can be fired again when the next time the atria start to pass that message on. So P wave is atrial contraction, QRS complex is ventricular contraction. We don't see electrical activity from the atrial repolarization because it essentially gets overwhelmed by the larger amount of electrical activity when the ventricles contract. So it obscures the electrical activity of the atria resetting themselves. You can see the T wave is even bigger than the P wave, and that's pretty typical depending on which lead you're looking at in the heart rate. And again, it is a larger amount of muscle mass that's resetting itself. So those are the common big spikes that you'll see. When we get into therapeutic procedures too, we'll talk a little bit more about the different meanings of all these different segments and things like that. But for this class, I don't think you really need to know a whole lot about that. Just knowing the P, the QRS, and the T, and what they represent is the most important part. This is a helpful slide I don't want to spend a lot of time on it just because we are somewhat limited on time today with everything I'm trying to get through. But it kind of shows you with these colorations and the images exactly what's happening in the different chambers and matches it up with where the tracing is at any given point in time. So this top one, we're seeing the very initiation of the SA node starting to contract and the right atria starting to contract. And that's when we get that first little upslope of the P wave. By the time we complete the P wave, we've essentially caused both the right and the left atria to contract. And then when it goes green, that's essentially when we're repolarizing things there. So if that helps you kind of wrap your head around the timing of these electrical spikes on the tracing, then spend some time looking at that slide. I'm going to skip that clip. I'm also going to skip this stuff. This is, again, more anatomy stuff. Hopefully you remember this from last semester. For those that had anatomy last semester, we've got 3 layers within both arteries and veins. We've got that internal layer, the intima layer that's directly in contact with the blood. We have the media layer, that's the muscular layer. And then we have the external layer, the externa, that's basically connective tissue, allowing things to anchor on and hold those vessels where they're supposed to be in the body. And we have both of those in arteries and veins. The biggest difference is going to be in that media layer. Arterial vessels are going to be a much stronger, thicker muscle than the veins. The veins do have that muscular layer, but it's much more limited in how much constriction it can do and how much force it can generate. All right, so our arteries, especially the ones that are closer to the heart, have a ton of elastic fibers in them. So they have the ability to basically accept a big surge of blood and kind of stretch, and then that elastic property lets it kind of rebound and squeeze tight again. So if you think about the aorta, the left ventricle all of a sudden is pumping out a large amount of blood. The average is about 70 milliliters of blood with each beat that we pump out. And if you think about like a can of Coke, that's 355 milliliters. So essentially 70 milliliters is about 1/5. So we're pumping out basically 1/5 of a can of a soft drink with each beat for the average person. And so that large volume is going through, not necessarily a super big tube. This is a big heart. This is bigger than life size. But even looking at it, that's, about that wide. So ventricle pumps it out. That proximal portion of the aorta in particular really has to expand a lot to accept that large volume. And then it's going to basically spring back just like a rubber band would kind of snap back. And so it lets us kind of spread out that wave of blood. Instead of just having this one big thick mass of blood flowing through a vessel at once, it kind of dampens it, spreads it out a little bit over time. So we get a little bit more of a steady flow because of the elastic properties of that artery. And when we start getting atherosclerosis and hardening and stiffening of those arteries, then we lose some of that ability to give and accept that large surge of blood. And we end up raising pressure, and we end up causing a kind of a back pressure where the ventricle is trying to push blood out. But if that aorta is really stiff, it can't push out quite as much, and we're going to have a harder time emptying that left ventricle as completely. So our stroke volume will tend to go down, and then we also create kind of this internal back pressure in the heart that starts stretching the heart muscle out a little bit. And so those are kind of hallmark changes that we see when people have chronic hypertension, is that their heart itself starts to get kind of too loose and baggy. And we talked about the length tension relationship was a question on the last test. And that's really a key thing. It affects the heart too. If the heart's really, really stretched out, then it doesn't have as much actin and myosin overlap. So it's going to have a harder time generating as much force when it contracts. And so it leads to this inefficient pump action when people have been dealing with high blood pressure for a long time. And that's essentially what causes congestive heart failure, which we'll talk about more in semester 4. All right, I think you guys know what capillaries do, so I'm going to skip that part. we do have our three primary types of capillaries. The continuous capillaries are by far the most common ones that we're going to have, and they're have pretty tight junctions between the individual capillary cells. We are going to be able to let oxygen and carbon dioxide diffuse out. Plasma can kind of leak out, ions, things like that. But the bigger molecules, the red blood cells, white blood cells, those formed elements, they shouldn't normally be able to escape those vessels very easily. The bottom two types are more porous. We have fenestrated, which are kind of the in-between ones, and then discontinuous. So discontinuous have much bigger gaps. So bigger things can flow in and out of those capillaries compared to continuous. And same thing with fenestrated. And when you look at the organs that these more porous capillaries are located in, they're the things that are having to process bigger stuff. The kidneys are in charge of trying to filter out, hanging on to the ions that we need, getting rid of metabolites, waste products that we don't need. And so they need to have a little bit more freedom in letting things leave the capillaries and then deciding, do I want to reabsorb that stuff at the nephron, or do I want to just let it go and flush it? The discontinuous ones, we've got the liver and the spleen, bone marrow. Again, the liver's modifying a lot of molecules. And so it needs to be able to take these bigger things that have been absorbed, like from the gut through the intestinal wall, chop them up, reshape them, reconnect different bonds, and then send them back out to do their job in the body. So they kind of need the ability to let big things get in or out of those capillaries. But most of the other body tissues are going to be fed by that continuous type. All right, our veins are very stretchy because they don't have a lot of muscle mass. So when pressure starts getting higher in the venous system, those veins will just kind of keep giving. And so we do store a lot of blood in the veins at rest. So if I'm not doing a lot of work, we have our 5 liters of blood on average in our system. A lot of that blood can essentially just kind of be held in the veins. It is getting pushed through the veins and getting back to the heart, but it's not returning to the heart as much as it could be if we really needed that blood. So when we start exercising more, then we're going to see the veins kind of tighten up a little bit, so that that blood that was kind of being held in reserve there now can make it back to the heart, and now the heart can pump it out to the skin, to the skeletal muscles, the body parts that really need to either cool themselves off or deliver a lot of oxygen and glucose to keep the muscular activity going. So veins are very stretchy. They're also very low pressure compared to the arteries. And so we are very reliant on the valves in the veins, as well as the muscle pump action. And then also our breathing cycles will also help drive venous blood flow and help it return back to the heart a little bit too. The arteries can kind of constrict and dilate a lot more precisely to change where blood is going. The veins are definitely much more reliant on some other mechanisms in the body to help them do their job in returning blood back to the heart, so we can send it out in the body once it picks up oxygen. So this slide is just showing you the valves. Again, these valves would be oriented kind of like the aortic and pulmonic valves, where the openings are facing upward. So the blood is pushed from the distal, from the lower legs, say, and then once it starts working its way up the leg, as gravity weight makes it want to backflow, those valves should close and not let that blood backflow when they're working right. When people have like varicose veins, that's essentially a valve that's started to leak. So you're essentially kind of letting blood backflow, and it's going to backflow back in that vein until it hits a valve that is still intact. And now we have a lot of extra blood collecting above that one that is working, because the one above it has failed, and we'll get this kind of swollen, and we notice them when they're superficial, and you can see those bigger kind of squiggling protruding veins on the back of somebody's legs is kind of the classic varicose vein. And it is basically just a failure of one or more of the valves in that particular vein that's not really able to do its job anymore. So muscle contraction is going to squeeze those on those veins. That's going to increase the pressure in the vein, and that's going to drive that blood back up towards the heart. And as long as the valves are still working, it will kind of sequentially, with each muscle contraction, gradually force that blood to keep going back and back up towards the heart. Now I think the next picture shows the breathing cycle. No, it doesn't. Take it back. So our breathing pattern also plays a big role. If we think about our inferior vena cava in particular, we've got the big leg veins coming back, kind of like an upside down V. They're going to hit the central inferior vena cava, and that's basically in our abdominal cavity. And when we breathe, our diaphragm is going to pull down and flatten, so our thoracic cavity increases, and it has less pressure because all of a sudden we've made that thoracic cavity bigger. When that diaphragm contracts and pulls down, it's pushing down and increasing the pressure in the abdominal cavity. So when we breathe in, pressure in the abdominal cavity increases, and that's going to squeeze that inferior vena cava and force blood up. And then once we breathe out, then essentially the opposite happens. We're going to lessen pressure in the abdominal cavity, but we're going to increase pressure in the thoracic cavity. And so that change in increased pressure in the thoracic cavity will now help further push that blood back up into the right atria from that inferior vena cava and deliver it there. So now that right atria is nice and full, and it's ready to keep the blood moving into the the right ventricle and beyond. So the valves, the skeletal muscles contracting, and our rhythmic breathing patterns all are going to help facilitate movement of blood through the venous system in particular. All right, let's talk about heart disease. And again, we already went through this with pathology, so I don't want to spend a ton of time on this. I will show you my, I can't remember when I put these in. I probably have had one other physician appointment since I put these in there, but I am fortunate in that my family has great cholesterol levels and triglyceride levels. My diet and exercise habits are certainly better than the average person, but I can't attribute these lab values to my habits as much as I can to my genetics. My dad has super, super low cholesterol. My mom has higher cholesterol, but really, really high HDL cholesterols. So my numbers are really good. And if you've never had your cholesterols done, I would highly recommend it because it's kind of like high blood pressure. If you have a problem, the sooner you find out about that problem and take steps to improve it, the better off you're going to be in the lifetime, because these are progressive deposition of fat in your arteries. And when your numbers are out of whack, it's just a very strong indicator that you're probably at much higher risk of developing heart disease. So total cholesterol, we want to see that below 200. Our LDL and our VLDL cholesterols are both considered to be bad types that are linked to higher plaque formations. So we want those numbers to be really low. Our HDL cholesterol is believed to be our protective or good cholesterol that helps to scavenge the other types of cholesterols, take them to the liver where we can process them and reuse some of those as things that will go into our cell walls, as things that will become steroid hormones and things like that. So we want HDL to be high. HDL typically increases with aerobic exercise is one thing that's been shown to increase it. And believe it or not, moderate intake of alcohol has also been shown to increase HDL cholesterol. I'm not telling everybody to go start drinking, but that's just what the science says. If you have higher total values and your HDL is very low, then that's a kind of a double whammy. It's saying you got a lot of cholesterol and most of it's the bad kind. So one simple number that they'll look at to kind of look at the big picture of how all your cholesterols are doing relative to each other is this ratio. The total amount you have divided by how much of that total amount is the good stuff. And so we want a ratio of 4 or less. So if we had 200 for your total and you had 50 for your HDL, then you'd be right at 4. In my case, I'm like 2.5, 2.3. My mom's is even better than that. Her total is usually like 180-ish, but her HDL is like 85. So almost half of her total cholesterol is the good kind. And again, that's between both of my parents having really good numbers. That's a lot of why mine are probably good. My triglyceride level is ridiculously low. Anything below 100 is really pretty low, and mine's below 50. So these are all things that just help you understand whether you're at high risk of developing heart disease because of this factor. Again, we've got all the other things that can lead to heart disease too: age, gender, smoking status, inactivity, obesity, stress, a lot of other factors too. But just talking about the cholesterol factor, these are the numbers you want to kind of pay attention to.
So something interesting happened to me in one of my classes. We talked about this very same thing, and I was running a lot then, and I was like, oh, I'll go, go get it checked out. And my genetic levels are terrible. My family has high blood pressure, high cholesterol genetically. And since I was running so much, I figured I could eat whatever I wanted because I was running all the time.
Mm-hmm.
But that was not the case in my labs. They showed, yes, my HDL levels were good, but my triglycerides were high, my LDLs were high.
Yeah.
And so they basically said, if you're this high running as much as you are, then you have to keep running if you're going to keep eating the way that you are. So I changed the way that I ate. And then when I had them checked again, when I was running less, they were better just by changing diet. And they tried putting me on one of those medications that's supposed to raise your HDL levels.
Uh-huh.
Nothing. The only thing that raised them was when I increased my healthy fats like avocado and olive oil, and increased my aerobic activity.
Yeah, and there's a lot of people that get put on statin medications, your Lipitor and Crestor and Vytorin and things like that, and they're very effective in helping bring down your total values, in particular in your LDLs, and lowering your risk. They do have side effects for some people, and one of those side effects is muscle weakness and muscle breakdown. So they can cause complications for some people, but there are some cardiologists that think like everybody should be on a statin drug, just to be extra preventive against this. And I don't agree with that. I think, but there are a lot of people that even when they do eat right, even when they do exercise right, their cholesterols and triglycerides can still be bad for genetic reasons. And so those in particular folks need to really strongly consider statin drugs to kind of help give themselves some help in that department. I think you do need to try and do everything. You shouldn't just rely on the meds and be like, oh, well, I don't need to start exercising. I got put on this statin drug. I don't need to quit, going to fast food restaurants all the time because I got put on this statin drug. You need to kind of go for all the above in those type of situations, because it is a huge risk factor for developing heart disease. And not only heart disease, but peripheral vessel disease too, where you can start having issues with circulation to the extremities, put you at risk of amputation and things of that nature. So definitely take it seriously. So we talked about myocardial infarction in pathology, and I think I made note of the cardiac enzymes. Your pathology book is not really very accurate when it talks about which cardiac enzymes are measured. The ones listed here are the ones that I'm most familiar with from working in acute care and looking at patients' labs on a regular basis and working with patients that have had heart attacks. And these are all basically signs that your cardiac muscle cells have been damaged. If we lose blood flow to those particular cells and they die off, the cell walls will break down, and the stuff that used to be inside of that heart muscle cell are going to leak out, and they're going to show up in your bloodstream. And so creatine phosphokinase, that's an enzyme that will show up. Lactate dehydrogenase, another enzyme that will show up. And then troponin T and troponin I. And troponin is basically that molecule that is on that myosin, or on that actin filament, that the calcium is going to bind to help move that tropomyosin filament out of the way. And so these are direct indicators that you've got muscle damage, and in particular cardiac muscle damage. So that's what they'll kind of watch, and it'll have a telltale kind of peak and regression depending on when the person's heart attack was, and how high those levels get will dictate how much cardiac muscle damage happened with that heart attack. So we see sky high levels of these enzymes. That's a sign that you've got a lot of your ventricle probably has been damaged and it's not going to work very well in the future. If it's just a little bit elevated, then we know that, well, you just damaged a little bit of that ventricle. You're probably going to be okay, but we need to do some other things differently to help make up for that. When we look at our EKG segment, we'll see a couple different things. And the most common area where you'll see a problem when somebody has either a lack of blood flow to the heart or actual heart muscle damage is this part that's in red called the ST segment. Once the ventricles finish contracting, but before they depolarize. If those muscle cells have been damaged in the ventricle, it takes them longer to kind of reset and be able to be repolarized before they can fire again. And so typically immediately after a heart attack, we'll actually see ST segment elevation, where instead of being right horizontal where the baseline is for all of these spikes, it won't return to baseline. You'll have the S segment come down, and that will immediately climb up a little bit above where the P wave line was before the P wave started. When we have just ischemia, not necessarily direct damage to the vessel, but a sign like when we exercise somebody and we're watching their EKG rhythm, when the ventricle starts not getting good blood flow, we'll actually see ST segment depression. And that's what's shown in this second image at the bottom right. So the baseline, it didn't bounce back up where the rest of this green segment is, it stayed down below. And again, it's just a sign that those particular cells are not getting good perfusion. And so before I was a PT, I used to do exercise testing and ran treadmill tests on people. And so this is one of the common things that we were looking for. When we started seeing ST segment depression, then that was when we would call the doctor into the room and have them present just in case something happened. We'd really ramp up our communication with the person being tested. How are you feeling? Anything feeling bad? And if that depression is significant enough, then that would be a marker that would tell us stop the test. It's not worth the risk of continuing to push this person because they're already showing signs that they're not getting good blood flow. So that ST segment is really kind of the key thing that they're going to look at with heart attacks. And either elevation or depression can be bad. All right. We'll finish going through these kind of weird heart things and then we'll take our little break. So our arrhythmias, normal sinus rhythm starting from the SA node is between 60 and 100. So even though average person's resting heart rate is 70, 75, it is still considered normal if it's up to 100 at rest. If somebody's heart rate's 95 at rest, it's not a sign that they're in good shape. Just because it falls into that normal range, that's a sign that you got a pretty little stroke volume if you have to beat that fast to keep up a good amount of blood flow. Below 60 is considered bradycardia. So I'm pretty much always bradycardic. Probably Allie probably is too. Tom probably is too. It wouldn't surprise me. Anybody that exercises on a regular basis, you're almost always going to be below 60 at rest if you're truly at rest. And true resting heart rate is first thing in the morning before you've gotten out of bed and you did not get awoken by an alarm. Because when that alarm goes off, you get a big sympathetic nervous system response, and that's going to jack your heart rate up. So it has to be a day when you don't wake up with an alarm, before you get out of bed, take your pulse, see what it's at, and that's considered your true resting heart rate. So we'll go over all these rhythms again in therapeutic procedures too, but these are just kind of some examples of how the EKG tracing can differ quite a bit with these different types of rhythm disturbances that we see. So the first two on the left, top and bottom, we've got sinus bradycardia. We see a big gap between where the QRS complexes are. With sinus tachycardia, we see a whole lot of beats in that same period of time. And anytime you see a strip like this displayed, these are 6-second strips. So you can essentially, to get a rough ballpark of somebody's heart rate, you can count how many big spikes there are in the picture, and that will tell you. So in 6 seconds on this top tracing, we see 4 QRS complexes. So that's essentially a rate of 40. We would multiply, because it's 6-second tracing, 60 seconds in a minute, we've got to multiply the number of beats by 10. If we look at sinus tachycardia down here, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 beats. So then we'd have to multiply that by 10. So this bottom one, the rate is roughly 110. The top, this rate is roughly 40. Now with both of these are considered sinus rhythms. We have a distinct P wave that precedes every QRS complex. And then we have a T wave that follows it. When we go over to the right-hand side images, on the top, we've got ventricular tachycardia. So these are big amplitude spikes. So that tells us that's the ventricle, not the atria, because the atria is not going to make that big deflection because it's not much muscle mass. But we don't see any P wave. We just see this series of ventricular contractions. And this is a super fast rate. Essentially, each one of these big deflections is a beat of the ventricles. And so there's probably at least 20 of them in this picture. I'm not going to take the time to count them, but there's a lot. But they are consistent. They are showing you that you're having a strong ventricular contraction. The problem is with this fast of a rate, you're not letting the chamber fill in between beats. So it's pumping fast, but it's not pumping out much because there's no time for that left ventricle to now let the atria fill it up. Again, the atrias aren't even contracting. So gravity is the only thing kind of helping the ventricles receive blood. They're not getting that extra kind of kick from the atria pushing down the remaining bit. So this is a very ineffective pump. It's a lot of work for the heart to beat that fast. And so it needs a lot of energy, but it's not getting enough time in between beats to let blood flow through the heart muscle itself either. And so this, if we don't reverse this rhythm, it's going to usually degenerate into what we see at the bottom, which is ventricular fibrillation. And fibrillation is just random electrical activity that is not an effective pump at all. So if we see VTAC and we don't shock the person or they don't spontaneously come out of it, it will almost always proceed to VFib. And then VFib, because it's an ineffective pump, will end up going to asystole, which is a flat line, meaning the person's dead unless you can get them back into their normal rhythm again. So both of these tracings on the right, if you're working with a patient that is hooked up to an EKG monitor and you're looking up at the screen and you see anything resembling either of these, I would be worried. The one on the bottom, you'll sometimes see something similar to this and it'll just be electrical artifact. And that can happen in particular if like the ground wire electrode comes off, then it can affect how the other ones are being read. And so if the person that you're working with is still awake, alert, talking to you, and you see this bottom tracing, it's probably not a bad rhythm. It's probably just that the electricity, the unit's malfunctioning because it's not grounded correctly. Electrodes have come off. Usually if you see this VFib, the person will have passed out because they're not pushing enough blood up to their brain to keep consciousness going. VTAC, they will be awake and alert typically because you're still getting a fairly strong ventricular contraction, even though the stroke volume is kind of small. We'll revisit all those in PATH. We talked about atrial fib a little bit earlier, and I don't have a picture of atrial fibrillation, but essentially you're going to have just squiggly line and then a ventricular contraction, squiggly line and then a ventricular contraction. So we won't see a distinct P wave. And it's not as serious as VTAC, or excuse me, VFib, but it still is a serious condition and it can lead to that clotting problem that we talked about earlier. And it will affect how well the heart can pump blood, but not nearly as much as when things go wrong with the ventricle. All right, I think I'm just going to finish this set of slides and then we'll be ready to take our break. And we have a group to present, I believe, and then we'll, whatever time we have left, we'll kind of work through the second set of slides that go over circulatory system. So lymphatic system runs basically in parallel with the circulatory system, and it does help reabsorb a lot of the plasma that has leaked out of the capillaries. So it assists the veins in kind of returning fluid back to the heart, but it also plays a huge role in the immune system. Our next chapter, once we move past this circulatory system chapter, is the immune system. So we'll talk more about the lymphatics when we get to that chapter as well. And the rest of this is just kind of anatomy that we have already kind of reviewed. So let's look at the big picture of the lymphatic system here. It does include specific lymphatic organs the thymus gland, because that's where we first start to make the T cells that are part of our immune system. The spleen is a big part of the immune system also. The lymph nodes, our tonsils are part of the immune system and part of that lymphatic system. And then we have all the actual vessels themselves. So we have two primary ducts where all the smaller lymphatic vessels will eventually dump their contents in. And both of those lymphatic ducts will end up tying in to the subclavian veins on either the right or the left side of the body before they dump their contents back into the heart chambers themselves. So our right lymphatic duct basically supply or absorbs lymphatic fluid from the right side of our face, our right arm, and our right kind of upper chest. The primary thoracic duct absorbs the lymphatic fluid from everywhere else in the body. So over 3/4 of the body is all going into that, just the thoracic duct itself. The right lymphatic duct is a much smaller amount proportionally. And so everything that's coming back from the legs comes into this center portion, this cisterna chylae, that's kind of where they recoagulate. And then it will carry back up basically right along the spine, behind the abdominal aorta, and return it back up to the right subclavian, or excuse me, the left subclavian vein up top here. And then same thing, left side of the face, left arm, all the rest of the abdomen, all that stuff's coming in that primary thoracic duct. All right, so let's take a break here, and then when we come back, we'll let our group present, and then whatever time we have left, I'll kind of try and get through as much of the next set of slides as we can, and I'll catch up on Tuesday with what we can't finish. So I have 9:23 on my computer, so take about 10 minutes and be back at 9:33.
Hey, Craig, can I finish up my shoulder ones real quick?
Sure.
All right. So pec major origin is the medial third of the clavicle and sternum and the costal cartilage of the upper six ribs. Insertion is the lateral lip of the bicipital groove to the crest of the greater tubercle of the humerus. And then the actions are adduction, medial rotation, horizontal adduction, and then it's flexion to first 60 degrees and first 60 degrees of extension from 180 degrees of flexion. And then the nerve innervation is lateral and medial pectoral nerves C5, 6, 7, 8, and T1.
Okay.
With pec minor, origin is the anterior surface of the ribs 3 through 5. Insertion is the coracoid process of the scapula. Action is the scapular depression, protraction, and downward rotation and tilt. And then the nerve is the medial pectoral C8 and T1.
Okay. And
then the teres major, origin is the axillary border of the scapular nerve, scapula near the inferior angle. Insertion is the medial lip of the bioccipital groove on the anterior surface of the humerus. Actions are shoulder extension, adduction, and medial rotation. And then the nerve innervation is the subscapular C5, 6, and 7.
Okay.
And finally, teres minor, origin is the axillary border of the scapula. Insertion is the greater tubercle of the humerus. The action is shoulder lateral rotation, horizontal abduction. And the nerve is the axillary C5 and C6.
Okay.
All right, and that covers all the shoulder, right?
Uh-huh.
Okay, awesome. Thank you.
Right, before we let our presenters start, we did take a test on Tuesday. Well, you guys took a test on Tuesday. I graded tests yesterday. Um, there was 3 questions that had a pretty low percentage of people that got it right, so I gave everybody credit for that. So that boosted everybody's grades just a little bit on there. I think after I did that, the average ended up being like 80, 81. So not too bad as far as the overall average is concerned on that one. So that's the third of our kind of smaller tests, and then we'll have the final still as well. We've got one more test. Our next one is coming up. It's the Tuesday before Thanksgiving, so it's not that far off. So we'll get through this information. We'll have the chapter on the immune system on Tuesday, and then hopefully I'll be caught back up. I can't even remember what's on Thursday, to be honest with you, but I'll figure out that before we get to Thursday. So anybody have concerns about the test or questions, specific things that you weren't sure of or that you want to dispute, take me to court about, see if we can get those answers overturned. It's not going to the Supreme Court either way. So, all right. Well, if you do have a concern about it, and after looking through your test and everything, feel free to send me a message, and I'll try and address your concerns and see if I agree or disagree with whatever argument you're making. But I am open to having those discussions. All right, so let's let our presenters go ahead. I see they've gotten their slides pulled up, so that's great.
Okay, so Mackenzie and I, we did it on MD and ALS. Okay, there we go. So what is ALS? It's a disease that affects voluntary muscle movement. So pretty much all your extremities, talking, your mouth, swallowing, any of the, like your heart and your lungs and anything that's not voluntary is usually not affected directly, but because when they get weaker, as they get weaker, then it will affect them eventually. So the motor neurons are gradually lost, which then leads to muscle weakness, atrophy, loss of function, and then it will lead to death. Men usually have a higher chance than women, and it's usually happens in the late or mid to late 50s is the average age that people will get it. There's no known cause for ALS. They think some of it is genetically predisposed, but usually it's not. Most cases are actually sporadic. And then they believe that it's caused by environmental trigger that will make it begin to happen. So there's a couple of genetic contributions. So Tdap43 is a protein, and it regulates a lot of expressions of many RNAs. A big one it does is Stathmin that they found. That is plays a big part in axon regeneration. So Tdap43 and SOD1, they misfold when they're being built, and then they aggregate, so they're not being able to get rid of that misfolded proteins. And then that will start interfering with the nerves, sending signals down to the muscles. Another huge thing they found was a lot of people with ALS have glutamate. It's a neurotransmitter that builds up in the nerve cells. And the problem is that astrocytes are in charge of getting rid of the glutamate after the nerves receive the signal. But the astrocytes, for some reason, aren't working and not clearing out glutamate. So instead of getting rid of it, it just stays in there. But then when you send another signal, more glutamate goes in, and then it just keeps happening. And they also found that people with ALS, their cells are more permeable to glutamate. So usually it needs something to help get the glutamate into the cell. But they found that in ALS, the cell walls become more permeable, so glutamate can just flow in without needing anything. So that just blocks up all of the nerves, causing problems with the signaling. There's a video that I want to show you. You can't hear it, Kenzie. Maybe unmute yourself.
You might have to exit out and go back to before you shared the screen and click on the little boxes at the bottom that optimize the sound and optimize the video. That seemed like it worked the last time.
Can you hear it now?
Mm-mm.
Amyotrophic lateral sclerosis is a fatal neurodegenerative disease affecting motor neurons, nerve cells in the brain, and spinal cord. Consequently, progressive muscle weakness and paralysis leads to death within 3 to 5 years. 5 to 10% of cases are familial due to inherited genetic mutations. 90% are sporadic, and the cause is unknown. Approximately 20% of familial ALS patients carry a mutation in the superoxide dismutase 1 gene. The mutated SOD1 gene results in a mutant protein that aggregates, harming the cells. Using gene therapy, our lab is tackling the disease by introducing a vector that delivers an artificial microRNA that specifically targets the defective SOD1 gene. Harnessing a natural cellular process of gene silencing called RNA interference, the vector is specially engineered to turn off expression of the faulty gene. A single injection into the spinal fluid targets the nervous system. In lower motor neurons, production of artificial microRNA prevents the defective SOD1 gene expression. The gene therapy also shows promising results in preclinical studies, significantly and safely silencing SOD1 specifically in lower motor neurons. By targeting the root cause, our lab's gene transfer approach could be the future of ALS treatment.
All right. So that was just showing how they become misfolded, become congregated, and they are working on a drug that supposedly will help get rid of that, but there still is no cure to ALS.
Okay, so muscular dystrophy is a hereditary condition that is a group of diseases that results in extreme muscle weakness and muscle loss over a period of time. And so the cause is due to gene mutations, which inhibit the production of proteins that are necessary to create that healthy muscle and maintain that healthy muscle. And so MD is an X-linked disorder that can be recessive or dominant, and there are many different types of muscular dystrophy, but all of the types result in the same loss of mass. So two common types are Duchenne muscular dystrophy and Becker muscular dystrophy. And these types are caused by a mutation in an X-linked recessive gene and is primarily found in boys. And so the DMD gene codes for dystrophin, which is a muscle protein. And the protein is found in skeletal and cardiac muscle, where its main function is to assist in stabilizing and protecting those muscle fibers. And so people with Duchenne and Becker forms of muscular dystrophy cannot make dystrophin on their own. And so that's necessary to build and retain this muscle mass. And so that's what results in the muscle loss. So these types of MD start with loss of muscle tone in the lower limbs, and they kind of work up the body. And then alteration due to gene change the structure function of dystrophin and can prevent the functional dystrophin from being produced. So without an insufficient amount of this protein, muscle cells become damaged as the muscles continue to contract and relax with normal day-to-day activities. So every time they contract and relax, that's causing damage to their muscles. So both of these forms are associated with cardiomyopathy, which weakens the cardiac muscle, causing difficulty to the heart pumping blood as it's intended to. So there is also no cure for muscular dystrophy. And so treatment can lengthen a person's life, but it will not stop the progression. And so treatment options include medications, including corticosteroids, etolesterone, golodirsen, and different beta blockers to treat the symptoms of the disease. And so physical and occupational therapy also are seen to help. and possible surgical procedures, but not everybody is a candidate for those surgical procedures. So the enzyme superoxide dismutase, SOD1, that we talked about earlier, assists in the destruction of the harmful oxygen molecules in the cells, which can prevent damage to the tissues. And so that is currently being tested whether or not it can improve the conditions where harmful oxygen molecules are believed to play a role in muscular dystrophy. Okay, so now we're going to talk about the similarities between the two that we talked about. And so there are many differences and few similarities between muscular dystrophy and ALS. And so both diseases have no cure. The treatments for these diseases are intended to improve the quality of life and treat the symptoms of these diseases. And physical therapy is seen to improve the quality of life of people with these conditions significantly and reteach their bodies how to move. And so both diseases are neurodegenerative and can lead to similar patient outcomes. ALS is a disorder that affects the part of the nervous system that controls voluntary muscle movement, while MD affects different muscles throughout the body. So both of them have an effect on muscle in the body. As these diseases progress, the motor neurons are lost during or leading to muscle weakness, and then atrophy of the muscles will soon result. And the muscles can become non-functional, and then eventually it'll lead to death.
Okay, so the differences between ALS and MD. So MD is passed down through hereditary, but ALS, on the other hand, is very sporadic and can be caused by an outside trigger. ALS affects mainly the voluntary muscles, while MD affects the muscles, but it also affects the heart as well. And that in return affects all the other parts of the body. People with ALS tend to live 2 to 5 years. They can live longer, but it's pretty rare. Just because it's very progressive, it's very quickly goes through. But MD, people can live up to 20 years, and some can live longer, but the average is 20 years. Unlike MD, which has several classifications, ALS doesn't really have any, it's just ALS. So I'll go to the next one. So my grandma actually had ALS. These pictures are 3 months before she died. She was diagnosed, she started having symptoms in 2003, so a pretty long time ago. They actually took them 14 months to diagnose what it was. At first, they thought it was Lyme disease, and the thing that she got checked for the first, as we talked about, is outside triggers. She had this rash on her leg that was super itchy, and it wouldn't go away, and they kept checking on it. They thought maybe it was a tick that caused it or whatever. And I guess similar to ALS, Lyme disease has similar symptoms to ALS as well. So they were thinking it was Lyme disease, and they're like, Lyme disease can kind of go away with some help. But she wasn't getting better. As she progressed in the beginning stages, a lot of people lose their lower muscular first, is the average. They can't walk or anything. But as you can see, she's standing. So that was another thing that threw them off, because she was able to walk and stand for pretty much the whole time that she had it. Yeah, she was tired, so she'd have to be in a wheelchair, but for the most part, she was able to walk around. The first thing that she noticed that would go is she wasn't able to grab objects very well. She would be weak, she'd drop things, and she wouldn't be, she's like, I don't understand, I'm just dropping stuff. And then another thing is she couldn't pronounce words that she usually could. There's some words that were really hard for her to pronounce. And then another thing that led up to that was she wasn't able to eat or swallow as well either. So that's in the result. So she probably died quickly because she didn't want a feeding tube and she didn't want to worry about that. So it was really hard for her to eat. But just watching her going through that was pretty crazy, and just how long it took them. They finally it took 14 months for them to finally diagnose that it was Lou Gehrig's disease. And and by then, it's like, well, we can't do much, you know, we can't help prolong her life because she's already gone downhill so much. And so I just wanted to show you guys about her because it's pretty interesting to watch the whole diagnosis process, like what they have to go through, that she did have an outside trigger. It's not genetic in her family because she's the only one who's had it. And she got it at 57 and she died at 59. And yeah, so it's pretty crazy watching all that go down. But yeah, she was still able to walk and stuff. So a huge thing that affected her was being able to talk, being able to eat, being able to do all that. And then can you go to the next slide? And this is Austin. So Austin has Duchenne muscular dystrophy. He's been in our ward for my whole life. And my brother's actually best friends with him. He was diagnosed pretty young. And right now he's actually 19 years old. In this picture on the very left, my left, I guess, he right now, so he can only move his fingers. And so that's why he has a roller to help flip the pages of the book. They actually did a surgery halfway through his life. They put a rod down his spine because he was like crumpled over so much it was causing him to have breathing problems. So they had to do that surgery. And then right now, I guess they've been working on oxygen because his oxygen intake has been pretty low. But he is 19 and the average is 20 years. So things are not looking so great, but he just keeps going. He's super intelligent. He graduated high school. He does everything. So his brain's like still functioning, but his body isn't. And so it's pretty crazy to like watch him be like so smart, to know everything's going on, but like watching his body like totally just crumple down on him. He's not able to do anything, eating super hard for him now, like everything like that. So, yeah, any questions?
All right. Well, it was not my intent to have this assignment end up with somebody that had such personal experience. It's not usually the way these work with this random draw, but it is tough. I mean, both of those conditions are really, really tough because the end result is the person's going to pass away from the problem. And like you mentioned, neither one of them affect the functioning up here. So people are very aware of the fact that their body is failing them and having to watch it and see. And so it's tough for sure to watch somebody go that route. I have a friend of mine from high school that's in a band called the Muffs. They're kind of a punk band that's been around a while, and their lead singer, who's a female, passed away last year from ALS. And hers was genetic. She had somebody in her family that also had it. So she had seen somebody else go through the process and then got diagnosed. And yeah, it is a tough thing to watch. And I mean, muscular dystrophy is really tough because it's a kid, and then you're thinking this poor kid's getting all of their years stolen from them. Whereas ALS, it's an adult thing, so at least and because it usually is kind of middle age onset, they've kind of gone through the prime of life, potentially been able to have kids and have a career and that kind of stuff before a lot of those things kind of hit. So it's a little bit, I guess, better in that sense, in that the person at least got to fulfill some portions of their lifespan with some, higher level activities and stuff. But for the kids, I'm sure it's tough, both for the children and the parents, and hard to stay positive through everything. You definitely need help, and I can definitely see where counseling could be a helpful thing for both the patient and the family members that are having to watch that person slowly decline. So they're both, definitely hard things to endure personally and family member wise. So thank you for sharing those perspectives. I'm sure it wasn't easy to rehash that stuff for you personally. So, all right, well, let me pull up my next round of slides so we can see how far we can get on this content. And I'll kind of do like I did with the other slides, the stuff that's more anatomy review, I'm just going to skip through and try and focus more just kind of on the chemical part, the electrical part, the pressure parts and things like that, to kind of give you some understanding of how blood flow is controlled in the body. That's what most of this set of information is about. So we talked about stroke volume last time. Again, that's the difference between the end diastolic volume and the end systolic volume, basically how much blood is the heart pumping out with each beat. And then this other term, cardiac output, used to always abbreviated as Q. And then at some point, I don't know, probably it was well before the rise of QAnon, so I'm not really sure why they took Q out of there. But it's now at least this book just says CO. I think a lot of places don't use CO because that's like carbon monoxide. Just confuses things. But cardiac output is how much blood is the heart pumping in 1 minute is what your cardiac output is. And so that is determined by how much are you pumping with each beat.
I don't think your slides, they're not showing.
You're right. There we go. Well, now it shot you guys over to this other screen. Oops. Can you see it now? Yes? Okay. I dragged my toolbar across and all of a sudden it was on top of my gallery view of all your smiling faces this morning. And so I wasn't sure if I had actually unshown what I was trying to show. So stroke volume times heart rate. How much are you pumping out with each beat? How many beats are you having each minute? And so that's what tells us what that cardiac output is. So we talked, when we went over stroke volume, 30 minutes ago or so, if that stroke volume becomes less because somebody's had a heart attack and the ventricles can't contract very well, or somebody has high blood pressure and it's hard to force that blood out of the ventricle, in order to keep your cardiac output up, then you have to increase the heart rate. And our heart rate is going to have an upper end. I mean, both of those values have an upper end. We can only increase stroke volume so much. We can only increase heart rate so much. But those are going to be inversely related, at least at a given cardiac output. If we have a great stroke volume, then we can get by with having a low heart rate. If we have a tiny stroke volume, then we need to have a really high heart rate to compensate. So average heart rate, 70 beats a minute. Average stroke volume, about the same number, 70 to 80 milliliters per beat. Again, that's like that fifth of a can of a soft drink. And so we get about 5.5 liters of blood per minute that we're pumping, which coincidentally is pretty close to what our normal blood volume is. They aren't necessarily related. It's just that's how the math works out. And it's going to be dependent on body size. Somebody that's bigger is going to tend to have a bigger cardiac output. Somebody that's smaller is going to have a lower cardiac output. Somebody with a bigger heart is going to tend to have a bigger stroke volume than somebody that's got a smaller heart. So it is, scaled to body size, but the stroke volume in particular can be affected by your level of conditioning quite a bit too. If you have the ability to really contract forcefully per given size of your heart, you can pump out potentially more blood and empty that chamber a little bit more fully. So what we'll see with people that have heart conditions, whether they've had something like a heart attack, that some portion of their heart muscle is now essentially dead and can't really generate force and contract. If you have congestive heart failure, that's most commonly caused by hypertension, long-term high blood pressure. It can also be caused by a heart attack itself. That's an inability of the heart to really effectively pump blood. And so those will both cause your stroke volume to go down pretty considerably. So the example down below, if somebody only can push out 40 milliliters of blood with each beat, which can happen when we have a low ejection fraction, then in order to pump that same 5.5 liters of blood, their heart rate's got to beat at like 135, 140 beats a minute, which when you're older, that starts getting up close to your maximum. The old formula that they used to use for max heart rate was 220 minus your age. So if we have somebody that's 70, we would predict their max heart rate to only be 150 beats a minute. And if at rest, you're already beating 135, 140 beats a minute, then to get out of bed and walk over to the bathroom is going to put you up at your max heart rate already. So anything beyond just minimal daily activity effort is going to be, you're not going to be capable of that. It's going to be extremely fatiguing, and that person's going to start getting really short of breath, start just losing the ability to deliver enough oxygenated blood to the tissues that need it. Now, when we get in better shape, we can increase that stroke volume. So both of these values, the 40 and the 100 that I have on these examples, are basically like 30 milliliters off what's normal. But if you have 100 milliliters per beat, then you can get by with a resting heart rate of only about 55. And so that's a pretty normal resting heart rate for somebody that's in relatively decent physical condition. And depending on their body size, then they're probably averaging closer to 100 milliliters of blood with each beat. So we can vary that quite a bit, and it will have a really dramatic effect on what the resting heart rate is going to do. And the higher that resting heart rate is, the less capability you have of doing increasing work. The lower your resting heart rate is, that means you've got a lot more beats in the tank that you could potentially call upon when you need to deliver a lot more blood, like when you're working really, really hard. All right, so we looked at the electrical kind of depolarization graph for general heart tissue. This one is kind of showing more what happens with the SA node, with the specific pacemaker cells. And again, these have what are termed leak channels that don't really close off, don't need any kind of a trigger to let the ions move. They're just kind of always open. And so after the SA node causes the electrical depolarization of the heart to start, it's going to fire those SA node cells, and then they're going to repolarize and reset so they can fire again. And this upward tick, this kind of reddish color here, is showing basically those leak channels in effect. This looks kind of similar to what we see when we talked about EPSPs being when we're trying to activate a nerve, and we're getting other neurons that are telling that particular neuron to start thinking about firing, and they're trying to get it more and more excited. We see that gradual increase of the membrane potential from the resting value. And when it gets high enough, then it's going to trigger those voltage gated sodium channels to open. And so that's kind of what we're looking at here. We never hold that resting membrane potential with the pacemaking cells. They fire, they reset, go back to their baseline, and then immediately we start having ions leaking out, regardless of whether we're getting any kind of outside nervous system influence or not. So we have this gradual reset, and then it fires, repolarizes, and then immediately starts to try and drift back towards that threshold mark to make it fire again. So this top picture is kind of showing you what would happen really without a lot of outside influence. The bottom is kind of, or this middle one is showing you if we are in a more fight or flight response and we're releasing epinephrine and norepinephrine from the adrenal gland to try and help increase heart rate, increase force of contraction, then we're going to cause that upslope from the baseline level to that threshold level to occur much more quickly. And that will increase our frequency of depolarization of the SA node, which will also increase the frequency of depolarization of the rest of the heart, so our heart will beat faster. So that's what this middle part's showing. If we have more parasympathetic influence, where the vagus nerve is basically saying, yeah, we don't really need to beat very hard, then we're going to see a much slower or shallow upslope on that gradual build back up towards that threshold value. So we'll have a decrease in our heart rate. So that person that has the resting heart rate of 50 is kind of more in this situation. The person that has that resting heart rate of, say, 90 is probably more in this middle kind of situation. But it really is affecting just the ramp up from the reset baseline value to that threshold value that opens up the voltage gated channels. The yellow portion of this curve looks really identical in all three of these examples because that's when those things are firing. And that's an all or none kind of thing. Once we hit that threshold, they're going to fire, and that depolarization, repolarization timeline is going to be the same, roughly, whether it's a really fast rate or a really slow rate. What changes is how quickly do we come back up to that threshold value that's going to trigger the voltage gates to open and cause that whole scale swapping of ions that make the cell depolarize completely and pass the message on to the AV node, to the bundle of His, to the bundle branch, all that kind of stuff. So that's what that slide's about. So our brain stem is going to coordinate with the chemical signals of our bloodstream, how much our pH has changed, how much oxygen, carbon dioxide are present in the blood that's passing through the brain. So the hypothalamus can kind of make sense of it, pick that up through our osmoreceptors, and then try to help the medulla, which is where our cardiac centers are, figure out how much stimulus they need to send through that vagus nerve. Because the vagus nerve is cranial nerve 10, so it's basically coming out from that brainstem area as well. And so the vagus nerve, is always going to be tied into that heart, but it does respond to whether we have a lot of those sympathetic hormones floating around in the form of epinephrine and norepinephrine, or whether we don't. And in the case where we don't, then we kind of let the normal parasympathetic tone kind of increase, and we slow the heart rate down and slow down the force of the contraction as well. So multifactorial stuff. We've got, the chemical things in our blood that kind of trigger the hypothalamus to do its thing. We've got the brainstem influence and the vagus nerve influence. And then we have the things that are in our blood in the form of those hormones that will affect contractility as well, both rate and force. All right, we talked about end-diastolic volume. We talked a little bit about contractility. And this other term, TPR, total peripheral resistance, is basically how hard is it for the heart to push blood out. And so I mentioned if you have hypertension, if you have atherosclerosis in your aorta and your other more proximal big arteries have gotten stiff, then it can't give as much when we get that wave of blood trying to be ejected out of the left ventricle. And that creates this back pressure or this extra resistance. So that would be just resistance at the level of the aorta. When we talk about total peripheral resistance, it's talking about throughout the whole body. All of the different blood vessels in the arteries in the body, all of the different arterioles that really kind of crimp off or dilate to either send blood to the gut, or to send blood to the skin, or to send blood to the muscles, that will affect that resistance. So when you're exercising really hard, and let's say you're doing a whole body exercise, you're doing something like cross-country skiing, where you're using, or an elliptical, where you're using your arms and your legs pretty significantly, we need those blood vessels supplying those arm and leg muscles to be really dilated. And the more vessels that we have in the body that are dilated, essentially that lowers your total peripheral resistance, because now you have more available blood vessels for that blood to flow into, and it basically kind of decreases the pressure. Think about like if in your house, if you have like let's say you have a two-bedroom house or two-bathroom house, and you have a dishwasher and you have the washing machine. If you have the dishwasher going, the washer going, two people taking showers, the pressure in the shower is going to be lower. It's going to take longer for you to fill that wash tub up because there's not as much pressure going out. That's a situation where we have less resistance. We have a finite amount of water that's able to flow through all those pipes. And if we have all the taps open, then it's going to lower the resistance and we're going to have lower pressure. If we shut off the dishwasher, we shut off the washing machine, we shut off the shower, one of the showers, and only one shower is running, now we have a situation with more total peripheral resistance because more of the valves are closed, but we have higher pressure where it is going because that's the only place it needs to go or can escape. So it can be helpful when we talk about these pressures and how it affects blood flow to either think about plumbing or an HVAC system and how you can close vents off in a certain room and that will redirect the air to a different room. That's kind of like our fight or flight response. If I'd eaten lunch and I was delivering a lot of blood to my gut and those vessels were very dilated and my skeletal blood vessels were kind of shut off, but all of a sudden somebody broke into my house and I had to fight them off, I'm going to basically shut off the blood flow to the gut and send the blood flow to my brain, my skin, my muscles, so I can fight and respond a little bit better. It does just kind of shift around those things. And again, the more vessels that we have dilated, the lower peripheral resistance we're going to get. The more atherosclerosis we have, and the more that we're limiting where blood needs to go, then that's going to tend to raise that total peripheral resistance. So related to those factors is going to be our end diastolic volume and our end systolic volume too. So end diastolic volume is preload, and so that's how much blood are we dumping back into the right atria before we fire. And if I'm standing up and I'm not really moving my legs a whole lot, I'm not really contracting my calf muscles a whole lot, that will tend to lower our preload. I'm upright, so gravity wants to pull blood down to my legs. And if I'm not like actively walking, then I have less of that muscle pump to help the valves push blood back to the heart. So that's a situation where you can have a lower preload. And if we can't put as much blood into the atria, then not as much blood is going to go to the ventricles, and our stroke volume is going to go down. So if we can maximize preload, then we can improve stroke volume. And so if you've ever, if somebody's going into shock, which is a situation where we have a lot of vasodilation going on, or we have a lot of blood loss, one of the things that they tell people to do is to have that person lying down, raise their legs up. So now gravity is going to help the blood that was in the veins in their legs flow back to the central body. That would be a situation that would increase preload, because we're trying to help the heart pump more blood to the body that is still viable and living. So doing things like that, changing body position will affect preload. If we look at a sport like swimming, where you're horizontal in the water, it's really easy to have a good preload because your body's not having to fight gravity. The heart's at the same level as your arms and your legs. But if we're doing an upright activity, running, walking, cycling, something like that, where our body's having to fight gravity a lot more, then we tend to have lower preload. So it's harder to keep that big stroke volume upright compared to being flat. And anytime if you're working with a patient and they start complaining about feeling lightheaded, one of two things. The worst thing you can do is to have them stop and just stand still, because then they're standing, they're upright, they're not contracting their leg muscles, so they're not able to use that milking action to help push the blood back up through the muscle pump. So you're better off either keeping them moving or trying to get them sitting or even lying down is the best. If you can get them lying down, then we can kind of help get more blood to the brain by making gravity our friend instead of having gravity be our enemy in that situation. So super important, because that is a really, really common thing that you'll see with a lot of patients that get lightheaded, start getting what we call orthostatic hypotension. They have low blood pressure because of the fact that they've changed positions and become more upright, and gravity's pulling all that blood down towards their legs. So it's important to understand that concept and apply it practically when you have patients that complain about those type of symptoms. Our total peripheral resistance that we were just talking about is called afterload. And that's essentially how much resistance to blood flow is there leaving the heart. And so if we have lots of our blood vessels crimped down because we're not using our skeletal muscles, because we're not really hot and we're having to send blood to the skin, then we'll tend to have a higher total peripheral resistance. It's harder to have a big stroke volume when you have a narrow opening that you're trying to push blood through. If everything's really dilated, it's a lot easier for that blood to flow through. So we talked about ejection fraction earlier, and so both a low preload or a high afterload would tend to decrease that ejection fraction. One, because it would be really hard to have a good stroke volume. The other, because you're going to not have as much volume in there to begin with, and you'll have a harder time having a big difference between the EDV and the ESD. Frank Starling law of the heart is an important kind of thing to understand it. And it's really, if you remember the length tension relationship, when we talked about muscle tissue, we're most capable of generating force when we put a little bit of stretch through the muscle, when it's considered at roughly like 120% of its resting muscle length. And so the heart kind of works the same way. If we can increase our preload and stretch those ventricles a little more because we're filling them up that much more, we've put the cardiac muscle on stretch. And then that's going to help it generate more force when it contracts. And if we can fill it more, stretch it, take advantage of the elasticity plus kind of the reflexive mechanism that when we do a stretch, it triggers a stronger contraction, then we can maximize stroke volume and pump more blood with each beat. So that's what this term Frank Starling refers to. It's two different people. It's not some one person named Frank Starling. It's somebody named Frank and somebody named Starling. And it is basically like the length tension relationship with skeletal muscle. We're going to reach a point of kind of diminishing return where we might overstretch it and not be able to get quite as much force, especially if it happens all the time. But in general, if we fill it up more, we're going to pump out more with each beat. Whoa, got a little click happy. This is just a quick kind of flow chart to try and help you understand these different factors and how they affect either the rate or the stroke volume to affect your cardiac output. The things that are in dashed lines are basically kind of things that would decrease stuff. The things that are the solid line would be things that would tend to increase things a little bit. I don't want to spend a lot of time going through the nitty gritty of this, but it is basically telling you if we have low mean arterial pressure, that means that we have less total peripheral resistance. So we're going to be able to pump more blood out. Certainly if you fill up the heart a little bit more, have a bigger end diastolic volume, have more stretch, both of those would maximize our stroke volume. And then the rate is mostly going to be affected by the nervous system influence, whether we're in that fight or flight mode and we're slowing things down, or excuse me, we're speeding things up, or we're in that rest and digest mode and kind of slowing things back down. So our cardiac output, we want that to match the body's needs. And if we're at rest, that 5.5 liters is fine. But when we're exercising, then our cardiac output is going to go up dramatically, like 20 liters a minute, 40 liters a minute if somebody's bigger and really fit. So we can maximize that stroke volume, by like 8 or 10 fold over our resting value for people that are really fit and exercising really vigorously. You think about that, like 40 liters of blood a minute. If you think about how big a liter is, it's basically 4 liters in a gallon. So you're pumping like 10 gallons of blood in a minute if somebody's exercising really, really hard. That's a lot of blood, especially when you think about 100 milliliters with each beat, maybe 125 milliliters with each beat. We got to pump a lot, and we got to pump fast to get those kind of rates. All right, I think we talked about most of these things affecting venous return already. Pressure is going to affect it. How dilated your veins are is going to affect it. We've got our muscle pump. We've got the key. We have to have valves that function. And then we're going to have that rhythmic change in abdominal and thoracic cavities pressures as we breathe in and out. When we breathe in, diaphragm's coming down. That's going to compress the abdominal cavity and increase pressure there, but decrease pressure in the thoracic cavity. When we exhale, we're going to lower pressure in the abdominal cavity and increase pressure in the thoracic cavity. And so that just cycles back and forth. And again, works very much like the leg muscle pump, rhythmically contracting, squeezing the vein, then relaxing, and that helps to increase venous return. So again, we can improve end diastolic volume. And if we have a bigger end diastolic volume, then we tend to have the ability to have a bigger stroke volume as well. What do we got? I got all of 4 minutes left. I didn't get very far. Slide 13. That's not good. I'm going to have about 30 slides left for Tuesday. I'll probably see what I can edit out a little bit on that. So when we look at all of our blood, that is nowhere near all of the water that we have in our body. The plasma in the blood is largely water with ions and some proteins mixed in. But of all the body water that we have, 2/3 of it's inside of all of our cells. And 1/3 of it is not. The 1/3 of the blood that is, or 1/3 of the water that is not in our cells is split between the interstitial space, that fluid space in between the cells that helps facilitate diffusion of things in and out of the capillaries. That's 80% of that. So only 20% of our body's water 20% of the 1/3 of the non-cellular body water is actually in the plasma. So we think about the plasma being this big source of water, and it is because it's kind of the most movable source of water, because we can either flow it into the interstitial space, we can direct it into sweat glands to make sweat, and then we lose that water. But we do, like I say, we do have a fair amount of water in our blood, but it's compared to how much water we have in the whole body, it's not necessarily that large an amount. When we run into a situation where this 1/3 of total body water, we start having even more of it in the interstitial fluid, then we get into a situation where we have edema. So edema is not usually that the cells themselves are overswollen. It's the fluid in between the cells that is where we're starting to have more fluid being contained. And that's where the body parts start swelling. It starts pushing against the skin that's kind of containing all those things, and the fascial compartments that are containing all those things. And we usually see edema most prominently in the legs, again, kind of because of gravity. And if we have poor venous circulation, then that's going to make it that much worse. So I think we'll just finish up talking about edema a little bit. So if we have high blood pressure, that's going to basically push blood out of the capillaries more easily. If we have lower blood pressure, then there's not as much back pressure in the vessels that is going to push that fluid out of the capillaries. But if it is, if we've got 180 over 100 for our blood pressure, well, that's a lot easier to push that blood out versus 100 over 80. That's a much lower situation. If we can't pick the fluid back up because the veins aren't working well, then it makes it hard to get that extra fluid out of those distal body tissues too. So that can definitely be a big contributor. And so when we see people that have a lot of bad valves in their veins, then that's going to affect that pumping ability. If you have somebody that has a deep vein thrombosis, that's a big blood clot that's blocking venous return from that one vein. And so those are situations that we would definitely see more edema in that extremity if the venous system is messed up. If we have the proteins in the plasma leave the blood vessel, then they're going to create their own osmotic pressure gradient that tries to pull more fluid into that interstitial space. And that would also cause more edema. We'd rather have those plasma proteins stay in the blood vessels or in the lymphatic vessels so that it creates this osmotic draw that wants to pull fluid into those tubes instead of letting it pull it into the open space in between our cells. So those are some of the big things. And certainly if our lymphatic system gets blocked or damaged, then that can cause big problems too. And we see that most commonly in a therapy setting with people that have had mastectomies done, where they take out the axillary lymph nodes and their arm will get really, really swollen as a result. They just, the arterial blood flowing down into your arm is trying to get picked back up by the venous system. The venous system is responsible for about 80-85% of that reabsorption, and the lymphatic system is supposed to pick up the other 10 or 15% of that plasma that's leaked out. And so if the lymphatic vessels are blocked, those limbs can really start to get swollen. In some developing nations, we have different parasites that can clog up the lymphatic vessels, and we have certain types of worms that essentially can burrow through your skin or be ingested and end up in your lymphatic vessels, and they basically take up residence in your lymphatic system. And so we see a condition called elephantiasis or filariasis. And so this gentleman here, I'm not sure, it's probably in Africa somewhere. We have these very distinct fascial boundaries that have trapped lymphatic fluid and created edema in these body segments. So you can see these arms hugely swollen, these calves. He has not been doing a lot of calf raises. That's just a lot of extra fluid hanging in there. And then in front, so Mo, you were asking me about this yesterday. That is literally nuts. Get it? Nuts? Nobody laughed. Okay, maybe not. So that's a scrotum, essentially that's swollen. There's nothing else in the front there coming off of there. So I was talking to Mo yesterday because he has a friend that works in the hospital setting and has mentioned seeing patients that have hugely swollen scrotums. And scrotal tissue, I mean, that outer covering is very loose. There's not a lot of tight compartment to it, so it's very easy for fluid to go there. We have tight fascial boundaries around our abdominal cavity, and water is going to find the path of least resistance. And that's an area where there's not really a lot of pressure from the outside holding things tight, so it's very easy for the fluid to collect in that area. And I haven't seen the scrotum that big before, but I've definitely seen very swollen scrotums from fluid overload and excess edema. Not fun for the patient to have, for sure. So I think we'll end on that note. I'll just leave that picture up, let you guys enjoy that site for a bit. So a couple minutes over, sorry. James is taking over Kenise today, so I'm on call in case he runs into any glitches, but otherwise, hopefully that will go well. And I'll see about half of you guys in lab this afternoon.
Are we using the same link, Craig?
Yes. Yeah, I made him the co-host. So you should be able to follow the same Kenise link that we've been using for the last month or so. And like I say, unless he runs into glitches, I probably won't see you in that class today. Okay. So I'll see you guys either this afternoon or next week, depending on if you got lab today.
Could I do some pass-offs?
Sure. I gotta find which sheet I have you on. There you are. Okay, what are we doing?
Okay, upper traps, lower traps, teres major, and levator scapulae.
Okay.
So upper traps, occipital bone, and new ligament on the upper cervical spinous process, inserts on the outer third of clavicle endochromium process, scapular elevation and upward rotation, and spinal accessory nerve. Lower trap, trapezius is the originating on the spinous process of the middle and lower thoracic vertebrae, insert on the base of the scapular spine. Action is scapular depression and upward rotation, and it's a spinal accessory nerve. And then teres major is the inferior axillary border near the inferior angle. And then it inserts on the medial lip of the bicipital groove on the anterior surface of the humerus. And the nerve is the medial, wait, what is the nerve? The lower subscapular nerve.
Okay.
I think, I'm pretty sure, yeah.
Yeah,
And then the levator scapulae.
go ahead. My
Oh,
sheet
sorry,
just says
what?
subscapular nerve, but it may be the lower one. I'm not 100% sure.
I'm pretty, I think that's what it says on our flashcards. It's the
Could be.
lower.
Yeah.
And then
Okay.
levator scapulae, transverse process of the first 4 cervical vertebrae, inserts on the vertebral border of the scapula between the spine and superior angle. Action is scapular elevation and downward rotation, and then nerve is the 3rd and 4th cervical nerve and the dorsal scapular.
Okay.
And that's it. Thank you.
Okay, you bet.